Joining us from Germany, Dr. Daniel Teschner from the University Hospital of Würzburg is going to be discussing what's new in imaging for fungal infection diagnosis. Daniel, it's all yours.
Yeah, thank you, Luis, for the kind introduction. And it's my pleasure to talk about imaging technologies in mycology. And these are my disclosures. And of course, I will focus on the molds. Yeah? The imaging is one of the major diagnostic approaches in the mold infection Aspergillus mucorales. So this will be the main focus. And I will first wrap up a bit about the standard of care techniques and if there is anything new in CT scans and MRI. And then have a look at the more advanced imaging techniques, which are at least to some extent in some setups maybe part of the standard of care. And here I will focus on the FDG PET. And last but not least, I will show you some upcoming imaging technologies that are more fungal specific from a metabolic and immunologic point of view. And you all know the conventional chest X-ray doesn't play really a role in detection of invasive fungal diseases, especially in the lungs. You can see here the bronchial carcinoma, but nevertheless, the conventional chest X-ray is not very sensitive, and that's the reason why our guidelines in the US and in Europe and all over the world definitely recommend computed tomography as standard of care, especially when focused on to the lungs and when you have cranial infections or CNS infections, you will head for an MRI. And you would expect in the MRI to detect minor lesions of the soft tissue, as shown here in the orbiter. But of course, in the guidelines and in our daily life, the pulmonary imaging is the most important thing. And we're heading for the halo sign. We're heading for the inverse or reversed halo, or whatever we are trying to think to detect. But as the speaker in the previous talk already said, this is definitely not specific. Yeah? This can be, of course, pulmonary aspergillosis, but it can also be Staph aureus infection, for example, of the lungs. So improvement here is needed. Therefore, there are some techniques or some strategies to improve the standard of care imaging, to become more sensitive or even more specific. And one approach is to go for pulmonary angiography to check whether you have any vessel invasion or occlusive signs. We know that the fungus is growing angio-invasive. You can use enhanced CT imaging techniques. And of course, you can combine CT and MRI and use specific MRI techniques. And with regard to angiography, we are heading for the vessel occlusive sign, as shown here. The vessel is breaking up, so this is highly suspicious for an invasive pulmonary fungal disease. Whether in this image here you have nicely the vessels going through the infiltrate. So this is a Pseudomonas pneumonia, and but if you would imagine you haven't here this angiography, this can also be used from a imaging point of view of fungal infection. Another technique is to enhance the CT by using different techniques here. Now, here you see the non-enhanced lesion, but if you have here the arterial phase and the venous phase, you can clearly see here the hypodensity, indicating that it's more likely fungal than a bacterial infection. Of course, we use MRI and CT techniques. We want to see whether there is a bone affection, or if we want to examine the soft tissue in detail. And you can additionally use specially TA-weighted techniques to distinguish in between the soft tissue between more fungal-like lesions or not. But nevertheless, this is always, yeah, you're trying to be more specific, but of course this is not specific. And when we try to get more specific and get more closer to the pathogenesis of the infiltrate, we can use metabolic or immunologic techniques to be more specific. And I will tell you some, or show you some slides with regard to the FDG pad with the labeled glucoses. But of course, there are also leukocyte or granulocyte techniques showing the infiltration in the fungal lesion or the fungal lesion. And of course, the PET is useful to detect metabolic activity. So if you have a lesion, for example, here in the orbiter, and you perform the PET, you see there is metabolic activity, but this information for itself, yeah, I don't know whether the clinical significance is very high here. However, you can also detect very small lesions, as shown here in this picture. There was a primarily problem in the lungs, but via PET, the colleagues were able to detect the adrenal infiltration of the fungus. Very rare, but not easy to detect in conventional imaging. And from my point of view, the most useful thing in the PET imaging is to assess response. This was a patient with an invasive pulmonary aspergillosis under treatment with liposomal ampho-B and isavuconazole. He responded well. From a clinical point of view, he achieved clinical cure, so no symptoms anymore. And the colleagues performed a PET CT scan in addition to the conventional CT scan, and they found metabolic activity left. So they didn't stop the antifungal treatment, they continued it to prevent here relapse, so to speak, relapse from this residual activity. And here another example, there was candidiasis here, and with involvement of the lungs. I think we can just discuss it extensively, whether this is whether this is feasible or not. But here we have the lung lesions and we have the hepatorenal or hepatosplenic invasion of the candida. He was in treatment with echinocandins. He responded well in the lungs and from a clinical point of view, but in the PET CT scan follow-up, you see there were still lesions left. So the colleagues continued treatment and didn't stop only because of biomarkers or clinical or conventional lab response. But this is also, this is very likely that it's candida, but it's of course not specific. It's only metabolic activity. It's inflammation that can be measured here. And to be even more precise and fungal, from a fungal specific point of view, there are upcoming imaging technologies, and I will talk about the siderophore-based molecular imaging as an example from my point of view, representative example, and antibody-guided immunopet or MRI. But there are many more of in vivo imaging techniques that are established, at least in the lab, to diagnose and cure mice. And from a scientific point of view, we have a lot of targets that can be addressed by vivo imaging. You can look for a deposition of the fungus in the lungs. You can visualize a germination rate. You can check the microenvironment or the epithelial uptake. There are, from an immunologic point of view or mycologic point of view, there are a lot of potential targets to address. And as we said before, it's one option is to label, of course, the immune effector cells, the macrophages or the lymphocytes, and check where they are fighting against the fungus. But another approach is to go for the fungus itself. So to check for fungal compounds, for example, the siderophores, the transporters. Fungus is always hungry for iron. or even label the antifungal drugs itself with tracers and therefore check whether they are enriched in the fungal lesion or not. And one, from my point of view, promising approach is the heading for the siderophores, and the colleagues here took gadolinium-labeled iron and checked for the enrichment of the iron here, of course, in mice, and they found, and they showed very nicely that the infection is of the mice is correlating with a nice enhancement of the radio-labeled compound, and therefore we can this is only enriched or are primarily enriched in the fungal lesion, of course. Another technique is, and this is even more fungal specific, you take the Aspergillus specific monoclonal antibody, label it with copper, and check in neutropenic mice that are infected by Aspergillus whether you can find or detect the fungal infection. And in the lab with mice, this works very well. So you infect the mice with the Aspergillus, and then you can find the Aspergillus infections very nicely with this antibody compound. So there is a very broad spectrum of possible techniques, but this is also all lab-based. Yeah? None of these techniques is still established in the clinics. So to wrap this up, we have, of course, our conventional techniques, CT scan, MRI, that are definitely the standard of care. And in combination with the clinical findings and with the microbiology findings, we are able to detect or to exclude, applying our criteria, whether it's very likely that it's a fungal infection or not. Though, of course, these are old techniques, but from my point of view, from a clinical point of view, they still work in the major in the major forms of infections. However, there is room for improvement, though there are techniques which are applied as standard of care in else indications, like the pulmonary angiography or other advanced techniques like enhancement techniques or weighting techniques in MRI that can improve our standard of care. And at least in Germany, it's not common to perform angiography in fungal diagnostics, though there is still room for improvement. Metabolic imaging by FDG PET is very useful from my point of view, at least in response assessment. Response assessment is critical because we have long-term treatment. We have a lot of antifungal drugs that cause long-term effects, so it's essential to know when to stop, and then FDG PET may be useful, also in detected minor or small lesions. However, it's also not standard of care, but I think it's very likely that it will become standard of care, as it is still part of the standard diagnostics, for example, in lymphoma, at least in Germany, and as I know from my European colleagues, it's becoming even more also used in other centers, but it's also a matter of costs. And luckily, there is a plethora of upcoming techniques, in vivo imaging techniques, that may give us in the future the opportunity to be more fungal specific, not only checking for the growth and the appearance of the lesions or their metabolic activity, but even to check whether it's really fungus or it's even more likely that it's really fungus that we are treating here. However, this is not established in humans now. There are a lot of proof of principle studies in mice, yeah, but it's not established in humans. It's definitely not commonly available, and I would assume that it's very that the costs are very high, because the tracers, for example, are not cheap to produce. We know this from other indications. So I think we have to deal for a long time with our conventional diagnostics. But as I said, there's room for improvement, and maybe the FDG PET will change the field a bit in the future. Thank you, and I'm happy to take questions.
Thank you very much, Dr. Teschner. That was a really, really interesting lecture. We have a comment from Dr. Nucci, who's mentioning he's seen 2 cases of invasive fusariosis with multiple liver and spleen nodules. And the clinical diagnosis had been chronic disseminated candidiasis. So definitely room for improvement there with imaging. From Dr. Samadar, how to overcome their uncertainty in radiological findings for non-neutropenic patients with IFIs and importance of scoring systems?
A very good question. The most data which are available are, of course, in hematology patients, in neutropenic patients. So it's always very critical if we, for example, are consulted by our transplant ID physicians with liver or whatever SOT. These findings are not as they are published for the hematology and neutropenic patients. There are some, from my point of view, good scoring systems available. For example, published by Oliver Corneli in Cologne, that can help, of course, to be here more specific. But from a clinical point of view, it's very tricky in neutropenic patients, because the leukocytes, the granulocytes, are of course fighting the lesions, and they don't appear as we would expect in the classical hematology patient.
Okay, how can we differentiate residual inflammation from true infection at the tail end of antifungal therapy?
Yeah, that's of course tricky. Nowadays we check in the CT scan if there's any movement in the lesions. If you have a stable infiltrate and there is no movement anymore, despite the fact that you are on antifungal therapy, you would say, okay, this is residual, no activity. We stop. Yeah, we stop and check again, for example, in a month or whatever. So I think in this case, the metabolic imaging can help or may help, as we know from for example, lymphoma or other indications. But of course, if the inflammation we are detecting here by the metabolic imaging is due to a residual fight of the immune system against the fungus, or a residual inflammation due to the scar, this cannot be distinguished. No.
Very good. From Dr. White in the UK, what are your thoughts on the utility of CTPA and the US occlusion sign as early indicator of infection, but also excluding IFIs?
Yeah, I've used it sometime, because it's I think all of us treated fungal infections that some weeks later shown to be, for example, Staph aureus or Pseudomonal infections. This is not as uncommon. And according to the data and also to my personal experience, the CTPA may help to distinguish here between fungal-like appearing bacterial infections and a real pulmonary fungal disease. But of course, it's not 100%. It's another step forward, yeah. But I think it's useful, not first line. I would not recommend it first line, but in difficult situations where you have a critical patient does not really responding, before I would escalate antifungal treatment without having the pathogen, I would at least try to go for angiography if the renal function is stable, of course.
And also from Dr. White, and this is something you've been thinking a lot about, I know, any sort of movement to standardize the way we report radiological evidence for invasive fungal infection?
Definitely, because I know how it is, for example, in your institution, but if a patient from my ward is sent to the radiology and they perform a CT scan, the likelihood that there is the word fungus in the report is very high. Nevertheless, how the image look like, because it's the suggestion. Hematology patient, I know these patients may have fungus. Okay, then you have the atypical infiltrates and so on. So I think there's definitely a need for standardization, but it's the same in the clinic. It's always a mix of the clinical picture, the mycological findings, and the imaging. So of course, I can understand our colleagues from radiology that it's not easy for them. Yeah, and we always talk and ask them, what is it? Yeah, and they only can, of course, describe the image.
Yeah, this is really interesting because a lot of us have been participating in clinical trials and adjudication committees, and we're really finding very difficult to evaluate the course of the illness based on radiology. There's a lot of discrepancy between percentage of improvement or not, and definitely an area that we need some standardization. I have a question for you myself. During your reading, did you come up with any sort of new articles about point of care ultrasound? All the intensivists and internists are walking around with little ultrasounds and doing chest ultrasound now in critically ill patients. Any utility of point of care for fungal infections?
Yeah, there were a lot of reports in the context of COVID-19 and fungal disease, of course, present on the ICU, and the colleagues. I think the ultrasound is getting a revival. So from my point of view, but we need to educate our colleagues, because the ultrasound of the lungs to detect pneumonia, I think, was left some years ago. There was always X-ray or CT scan, but during the COVID pandemic, it became a revival. And of course, if you have an experienced investigator, you can at least get some clue, some hint whether it may be more fungal or bacterial-like. But this is very highly sophisticated, and there, in this case, also we're trying to establish courses here to improve education and to make the residents be able to perform this techniques.
Thank you very much for that great presentation.